Good morning, everyone, and happy Thursday. Welcome to today's roundtable about cancer care disparities in Tarrant County. This panel is a collaboration between several groups. We have Cancer Care Services, we have the University of Texas at Arlington, and the University of North Texas Health Science Center, and then panelists from various other organizations that you will meet in just a minute. I'm Alexis Allison, a health reporter at the Fort Worth Report, and I will be your moderator today. So if you are in the audience and feel comfortable turning on your camera, go ahead and do so now. And I'd just like to ask you a quick question. I like to have a little bit of audience participation. So if you could raise your hand if you are a woman who lives in Texas, or if you know a woman who lives in Texas. Excellent. Great digital hands. Beautiful. So cervical cancer is preventable. However, if you are a woman who lives in Texas, you're more likely to develop cervical cancer and die from cervical cancer than your peers in more than 40 states. If you're a Hispanic woman, your likelihood increases, especially if you live along the state's southern border or in counties like Tarrant. The goal of this morning's panel is to understand why and how we can together create change and address those issues in Tarrant County. I'm going to briefly introduce our panelists and then share the format of today's panel. So panelists, if you could smile and wave as I introduce you in alphabetical order by last name. So we'll start with Crystal Acosta. Crystal is a community health worker and a community outreach coordinator at Moncrief Cancer Institute, as you can see by her background. She works to educate communities on the importance of the prevention and early detection of cancer. Thank you, Crystal. We have James Earl. James is a licensed social worker with over 10 years of experience in the field of social work. He's also the Director of Outreach and Health Equity at Cancer Care Services, where he leads a team of community health workers. We have Dr. Autumn Kiber Emmons. Autumn is a family physician and health policy researcher with a focus on cancer disparities in Hispanic populations, who is funded through the American Cancer Society for a research study aimed at better understanding cervical cancer disparities among Hispanic women in different Texas regions. We have Carlene King. Carlene is a community health worker and outreach coordinator also at Cancer Care Services. As a cancer survivor herself, Carlene walks hand in hand with a cancer patient from the beginning of their diagnosis all the way through to the end of treatment, recovery, so they don't have to go through any of it alone or without hope. We have Marcela Nava. Marcela is a health equity researcher who studies the political economy of health, good times, and public policy to look for what works in reducing health inequities and protecting community health. She's an assistant professor in the School of Social Work at the University of Texas at Arlington. Then we have two more. We have Erika Thompson. Erika is an assistant professor in the School of Public Health at the University of North Texas Health Science Center. Her research focuses on HPV-related cancer prevention, with an emphasis on HPV vaccination policy, HPV vaccination for adults, and cervical cancer screening. And then we have Alma Zuniga. Alma is a 7-year cervical cancer survivor, a mother of 3 boys and grandmother of 3 beautiful grandkids. Alma's mission is to be a voice for the cause, as well as educate women about cervical cancer. She works in the insurance industry and has never met a stranger. And Alma, I think you're coming to us from which city in Texas did you say?
I live in Fort Worth, Texas. I live in Tarrant County, but I happen to be in Canton this morning, or today. So it's beautiful, beautiful day.
Yes, I'm jealous. So as you can see, we have a big and good panel. So to kind of help the audience members keep in mind who is who, just a few quick questions for our panelists. So panelists, if you are a researcher, raise your hand. Okay, beautiful. If you're a physician, raise your hand. If you are a community health worker, raise your hand. Beautiful. If you work at an organization that helps people with cancer, raise your hand. Wonderful. If you've had cancer personally, raise your hand. Wonderful. Thank you. So we will begin with a 40-minute panel discussion, and then we'll take a brief break and then split into breakout rooms to discuss what we've heard from our panel discussion. And then finally, we will return for one last round of questions that are inspired by the breakout room. So what I encourage you to do, audience members, is to grab a Google Doc or a pen and paper and write down questions so that you can share them in the breakout rooms, and then in our final segment together, ask them to the panelists. Okay, so I think we should begin. Dr. Kiber Emmons, I'm directing this question at you. Before this panel, you said to me, nobody should die from cervical cancer. Why is that?
Yeah, so thank you for starting it off with that. So I think it's key for us all to remember that cervical cancer is a long trajectory from, the virus to dysplasia, to precancer, to cancer, to invasive cancer, to death. And the medical establishment knows that there's many points along that way that you can intervene so that a woman would never have to pass away from cervical cancer. So I think that we're all here today recognizing the extreme inequity that we see with disparities in certain populations and certain geographic regions where cervical cancer rates and then, God forbid, cervical cancer mortality is higher.
Well, so a follow-up question for you then. I know that your research asks why Hispanic women are more likely to die from cervical cancer than non-Hispanic women. What have you found?
Yeah, so we did an exploratory study that was funded by the American Cancer Society because of their mission to think about HPV and cervical cancer. It's one of their top priorities right now. And so it was exploratory. We don't have any absolute answers, but one of the things that we did with our team was really a lot of on the ground work with many folks and organizations that you all are representing here today, to understand what are the things that are happening in certain geographic areas in Texas, many of which include some of the things that Marcela hopefully will talk about with relation to policies, insurance status, challenges that folks who are Hispanic may have from either immigration status, language, insurance barriers, et cetera. And then some of those bigger like socio-political types of things that could really impact a woman's access or ease of access, through that trajectory from pap smears to colposcopies to cervical cancer treatment to no treatment to death.
Well, I'm glad you brought up Marcela. So Dr. Nava, I'm throwing this one to you. First, when we talk about Hispanic women aren't a monolith. Can you tell us who we might be talking about when we talk about Hispanic women?
Sure, and you're right. Hispanic, when we talk about solutions to hear Hispanic women are at higher risk of dying from cervical cancer, it doesn't tell us much because the way that we report cancer statistics doesn't include a rigorous measure of what race or ethnicity is. In fact, we can't really agree on what race or ethnicity is. And so oftentimes it may very well be just that somebody checked a box or somebody checked a box on behalf of somebody else that said Hispanic. We know that what it means to be Hispanic in New York City may mean something completely different than it means here in North Texas. So when we talk about Hispanic, what we don't know is specifically being able to look at data that tell us, is this associated with language? How many of these women report language barriers? How many of them report an immigration status that would basically make them ineligible for state, federally, or even county funded treatment? So when we talk about Hispanic, what we can safely assume based on the data is that a large proportion of them are likely to either be people that are non-US citizens or to be part of a family that has a non-US citizen. So it may very well include US citizen-born children with a family member whose relationship with the healthcare system has shaped their own access.
Thank you for explaining that. And can you bring it down to Tarrant County when it comes to, for example, Hispanic women who might not be documented in Tarrant County, what are some of the public policies in place that could serve as barriers to their care?
Yeah, so one of the things that is really difficult to wrap your head around unless you're a glutton for punishment and you like health policy like I do, is just the way that our healthcare system is set up, which means that we have pockets of funding from many different streams for many, many different things. And as Dr. Kiber talked about, we may have one source of funding for prevention for pap smears that's not being accessed, but is accessible to most women. Then we may have state funding for Medicaid, which in Texas, each state can actually set its own policies, but in Texas, the state has opted not to extend Medicaid, not just under the ACA, but not to extend Medicaid to people that are not permanent residents that have been here for at least 5 years. So when you look at the lack of federal funding for treatment, the lack of state funding for treatment in the state of Texas, coverage for people who are uninsured is a responsibility of each county. And so each county can set its own policies around who to cover. And then in Tarrant County, county policies around the public hospital district's financial assistance program set eligibility standards that would make somebody that's not a permanent resident basically ineligible for treatment for cervical cancer under county policies.
Thank you. So essentially, we have counties that are able to dictate who is allowed to get this funding. And one of the terms that you mentioned is resident. Can you talk about the kind of complications around defining who lives in Tarrant County?
Sure. Resident is even more muddled than the word Hispanic, because resident can be in reference to a lawful permanent resident, which is a federal designation. But if you think about the fact that each state can set its own policies, a state could choose, for example, to extend Medicaid to permanent residents that have been here for less than 5 years. So while that person may not be eligible for federally funded healthcare under their state definition, they may be considered a resident for eligibility purposes. And then when you look at the fact that then a county may define or a state or a county may define resident in terms of people that are geographically located in a space, much like we think about residency for in-state versus out-of-state tuition for a public university. A state and a county can then choose. In the state of Texas, there's actually a lot of legal jargon and ambiguity. But as of right now, the last legal opinion that came out of the state capitol basically allows for counties to use the federal definition of residency, which means that there may be folks that would meet the definition of in-state tuition, say, to go to UTA, but they will not meet the definition of residency to qualify for financial assistance to pay for their cervical cancer treatment. Just to make it nice and complicated.
I know it is confusing, even if you're working in this space day to day. So for the people who aren't working in this space, I imagine it's even more befuddling. And so I want to swing to first Carlene, and then we'll go to Crystal as people who work in the community with people who may not be in the healthcare system day to day. What sort of barriers are you seeing when it comes to accessing cancer care? So Carlene, if you could start.
Well, a lot of what I see out here, in addition to the language barrier, a lot of times, is you've got the women who are the caretakers of the family. And they're not really as interested in themselves and their health as they should be. They're more focused on their family. So I think we're seeing a lot of the health problems as far as the cervical cancers being, escalated because people aren't aware that there are resources for them to, to get their screenings. And back to kind of Marcela's point, If we have someone who is maybe not documented, not a resident, okay, what's my options? So even if they know that there may be something wrong with me, because I can feel that, I don't have any options, is what they assume. So they just don't ever bother to reach out.
Thank you. And then Crystal, can you have your own experience then?
Yeah, so I think a lot of the times that I go into communities, you know, whether it's rural or urban communities, a lot of the times what I've noticed is the lack of financial resources and also the lack of the public health infrastructure that is required to successfully deliver those screenings and that follow-up care. And as Carlene mentioned, you know, the language barrier is another one. And then, you know, like Marcela mentioned, the immigration status, a lot of times people are afraid to go into the clinics because of their legal status, because of the language barrier. And then to top it off, you know, just defunding public health clinics historically associated with providing those preventative services like cervical cancer screenings to low-income women. They continue to impact the delivery across North Texas. And so sometimes, you know, the demand just continues to outpace the capacity that we're able, you know, that we're able to deliver these screenings as well.
Thank you. So it seems like we have quite a confluence of factors that go into these different outcomes for women in Texas. We've mentioned access, so language barriers, immigration status. Carlene mentioned not necessarily being aware of the options that are available in the community. Alma, I would love to go to you, and I wonder if, as someone who has experienced this personally, you could share a little bit of your journey with us and what barriers you encountered as you were looking for care and how you overcame those.
Well, fortunately, I was employed and I had health care insurance. I had just started with State Farm 6 months prior to my diagnosis. Prior to that, I had worked as an independent contractor, so I had no insurance. So I often wonder what that would have looked like if I had been a patient with no coverage, because I know the bills that I've seen that were billed to my insurance company. Through the process of going through the chemo treatment, I did run into some people that were non-insured, and they were immigrants that were at the center that I was at. And it was very interesting because when I had my port put in, I was sent to a surgeon and went to the hospital and did, you know, just like a regular outpatient surgery. And there was a young man that I had met that was in his early 20s that because he didn't have insurance, they actually did the procedure there in office. And there definitely is a difference when you walk into a facility and you either have insurance or you don't. You know, so just looking at the people that were being treated at the center was very interesting, because they are treated, not so much treated differently by the nurses, but healthcare wise, there is a difference. Through the center that I was at, I did see several people that were immigrants. And it's interesting just to listen to the different topics that are being discussed, because as a survivor with healthcare insurance, I never really looked at the other side of it to see, okay, how are these people being treated differently when it comes to their treatment? Because even though we don't want to think that that's the case, it certainly is the case. So as far as my journey, I was fortunate enough that I did have insurance. The cost of treatment is so expensive. And I mean, to this day, out of pocket for my part, I still am dealing with paying some of those expenses. And I had health insurance, and it was very good health insurance. So insurance has changed tremendously over the years, and I know that because I have been in the healthcare industry, or I had been in the healthcare industry for about 10 years, and then transitioned over to property casualty. But just the insurance industry as a whole has changed in the 35 years that I've worked in it. So it's extremely concerning to listen to the conversations that I'm hearing in regards to people with no insurance and people that are immigrants. So I'm grateful that I did have insurance, that I didn't experience a lot of the things that I'm hearing. So for me personally, it was never an issue as far as where am I going to go to seek treatment, because I had insurance. You have insurance, you're welcomed everywhere. If you don't have insurance, the situation changes.
Well, I want to come back in a little bit to different treatment depending on who you are. But despite the fact that you had insurance, I know that you told me that you one of the challenges is that you kept your cancer a secret for a while. Can you tell us a little bit about that and what ended up making you willing to share?
I did. You know, when I initially was diagnosed, I had been married for many years, and my husband stepped out on our marriage. So it's not like I was out being promiscuous. That through the course of just going through the treatment, you know, I heard different stories about physicians kind of making people feel awkward because, you know, because of the fact that they did have HPV that turned into cancer. But I kept it a complete secret from my employer, from my friends, because I was embarrassed. I was embarrassed that I had, you know, gotten HPV because, you know, I had a spouse that was irresponsible and came home and brought that to me. So, you know, it took going through treatment and really understanding the importance of getting the word out to people about vaccinations, to women about self care, to making sure that we make ourselves a priority. Because I get when people say, you know, they don't want to talk about it when it comes to this type of cancer. I didn't ever want people to approach me and say, well, what kind of cancer do you have? Because, you know, as I explained to Alexis, not all cancers are pink. You know, when we think of cancer, we think of breast cancer. But this type of cancer, there is a stigma over it that, you know, it makes people in my position really, really careful about wanting to share what has transpired. I have a friend of mine that her mother passed away and went through treatment. She'd gotten HPV, cervical cancer, and we never knew because of the fact that she did not want to let anyone know. It took just a big coming to Jesus about my journey and understanding that it is important. I am responsible to go out and to teach the community of the importance of being vaccinated, of the importance of going and having your annual checks, the importance of going and having your mammograms. You know, a lot of women they do not do that because they are so worried about taking care of family, friends, jobs, that we make ourselves, you know, less of a priority. So it is my mission to make sure that anyone that I come across, that I remind them the importance of taking care of ourselves by going and having a well woman, by going and, you know, doing the things that we need to do. But I kept it a secret for, it had to have been a year and a half before I actually could come out and speak about it. And we've got to stop that. We can't, because our voices will help to save someone else's life. You know, and at the Zumbathon that I attended a couple of years back, I did speak there, and I had a young lady that came to me after I shared my story and told me that that she appreciated that I did that because she was experiencing the exact same thing. And by listening to my story, made it okay for her to share hers. So I share because I never know whose life I could potentially save. So it's nice to be able to go out and help the community and let people know that it doesn't have to be a secret. You know, we're here to fight the battle and to support one another and to let women know that we matter in this world. So, I will share my story with anyone in regards to what happened in my life.
For bringing this stuff Alma and sharing. And I'd like to go to Dr. Kiber Emmons as a physician. Alma mentioned the stigma of cervical cancer, and I'm wondering, as a physician, how do you help patients feel safe to discuss their concerns with you, especially when it comes to cervical cancer?
Mhm. I can only speak, I guess, for myself and how I take care of patients, but I think coming from a place of a family physician's training, no judgments, and also the ability to explain to women how common HPV infection is in America can help a woman who might have dysplasia or cervical cancer recognize that it's something that's really evident out there. I love what Alma said about self-love. I think a lot of this work really is trying to support patients to recognize their value and their worth, and that it's important to care for yourself and to follow through on the recommendations of your doctor, or medical recommendations that are out there for your age, etc. So just having a loving environment. I think a lot of women too, there's questions sometimes about the gender of providers, but I think that there can be certainly male providers who are my colleagues who have been able to adequately provide for a woman that safe space that they can talk. So I think that it's just the individual provider-patient relationship in that respect.
Thank you. And both of you have mentioned taking care of yourself. And so I wanted to swing to Dr. Thompson when it comes to taking care of yourself in terms of cervical cancer prevention. Can you talk about the options that exist today and maybe some that are coming down the pipe?
Sure. Thank you so much. And thank you so much, Alma, for sharing your story with us today and trying to break the stigma around HPV and cervical cancer. As Alexis mentioned, there are several ways that we can prevent cervical cancer, and aligning with what Dr. Kiber mentioned earlier, nobody should die of cervical cancer, because in our lifetime, we could see the elimination of cervical cancer around the globe. The World Health Organization has really set out these ambitious goals all around vaccination, screening, and treatment, so that if countries are meeting these goals, really bringing down those rates of cervical cancer. So here locally in the United States, our options include things like HPV vaccination. So that's where we can prevent those HPV infections from occurring in the first place. And it's recommended for 11 to 12-year-olds. So if you have teens in your life and if they haven't been vaccinated, that's a great opportunity for them. So that way they can prevent not only cervical cancer, but 5 other types of cancer as well. And they can get that vaccine as early as age 9. The second opportunity, as we've heard already, is cervical cancer screening. So having a pap smear every 3 to 5 years, or an HPV test once you become 30. It's really based off of what your doctor recommends, but there are a few screening protocols that are available in terms of using a pap smear or an HPV test. And as Alexis alluded to, I think there are some really great opportunities coming down in the future with self-sampling for HPV as an avenue for screening. So while it's not currently FDA approved, a self-screen would be something that a person with a cervix could do at home in the comfort of their own home, and do a swab and mail that kit in. I think this has a lot of opportunity to reduce some of the disparities we see, knowing that a majority of the cervical cancer deaths are associated with people who may have never had an early screen. So if we can find ways to reach people who otherwise wouldn't have an opportunity to screen through something like an at-home test, similar to like what we see with fecal tests for colon cancer. I think there are some opportunities there in the future, and that's where people like Crystal and Carlene here, community health workers, making those connections. I'm really optimistic about the future for prevention. But I'll just close with, if you know someone who's eligible for the HPV vaccine, that's really the first start. I always have to give the plug if I can.
Great. Thank you for that, Erika. And I think that transitions us nicely. I feel like we've delved into the problem, which is multifaceted. We know that cervical cancer is preventable. We know that there are a lot of prevention tools that already exist and that are here in the community. And yet there are certain groups that aren't accessing them as frequently as other groups. So if I could summarize some of the issues, as some of you've mentioned, we have a lot of access issues like language barriers, insurance access, immigration status. We have, I think Carlene and Alma both mentioned a tendency maybe for women to be taking care of others rather than taking care of themselves, a lack of awareness of the options and tools that are in the community. We have what Dr. Nava mentioned, this public policy that, at least in Tarrant County, disallows people who are undocumented from accessing prevention care at JPS Health Network, which is our county's hospital district. So am I forgetting anything? Dr. Nava, anything else you'd like to add? Dr. Kiber Emmons, anything else to add?
I think I do want to just say one last thing. One of the things in our research that was pretty unsettling to find was that there may actually be treatment differences based on insurance status. So beyond just in prevention. And I know that Marcela touched on that, but I think it's really important to hear that. And it's not because of a bias on the physician's part or a disinterest in providing equal services, but something about the system that makes it unable to be in the current system equitable across treatment, which is something that is a problem.
Can you elaborate a little more on what is in the system that's creating that? And then we'll go to James.
Yeah, I think, it's what Marcela was talking about in terms of just payer type coming in for what is accessible for different types of invasive cervical cancer, evidence-based treatment protocols with relation to chemotherapy, but then also radiotherapy that is only provided at certain sites. And if you have limited insurance access, it might not be something that you are able to access.
Thank you for adding that. Go ahead.
Yeah, I wanted to touch on Autumn's point about the system. I was having a really candid conversation with one of our bilingual community health workers, and she was expressing her frustration in the lack of resources for our undocumented residents here in Tarrant County. And, I was explaining to her, and this is just a cruel reality, that it is really difficult to address problems, concerns on an individual level without really looking at the system that created the issue. And so, with that said, it's incredibly frustrating, as a community advocate, as a social worker, to ask a group of people to participate in a system that is not designed for them to thrive in any way. And so we can say, okay, go get screened. And once you're diagnosed, if you're an undocumented resident, then you can't get treated. And so it's a really difficult reality that we're dealing with here on the front lines. And I just really wanted to make note of that.
Carlene, I'll jump to you, and then Dr. Nava, if you still have something to add, we'll go to you as well.
Well, my comment is really pretty quick, and it ties to what James has just said, and also a big part with what Alma said. we have to really be conscious of the trust factor that's out there. So one, you've got a community that doesn't trust the healthcare system. And then as far as community health workers, we're out there trying to promote the HPV vaccine. Now you have a trust because we're speaking with parents, because these are minors that we're trying to get vaccinated. Those parents don't trust us. You know, what are you doing to our kids? And, you know, they're not really believing that, you know, what we're telling them, get this vaccine to prevent these types of cancers from happening. So we have to make sure that we're aware of that when we're approaching people, that, you know, we have to have the trust factor. We have to establish that bond with them first and gain their trust before they're going to listen to anything we're saying.
And in a little bit, we'll come back to how we might build that trust. Thanks for bringing that up, Carlene. Dr. Nava.
And I think, you know, speaking at a political level, I think one of the elephants in the room that we often don't want to talk about is the politics. We live in Texas, and Texas is definitely leading the state in terms of the number and frequency of what we would call restrictionist policies, of policies that seek to limit access to resources based on things like immigration status and other factors, you know, that are certainly in the news. But it's really important to, I guess, keep in mind that even though there may be executive order after executive order that gets kicked back or maybe gets nullified in a court case, there are clear messages that sends to people in the community. And the recurring message that a lot of people in immigrant communities and families hear is, you are not wanted here. We are making every possible effort for you to not be able to access resources. So that message is heard loud and clear. That message severs trust between a lot of immigrant communities and healthcare systems. And so I want to emphasize that trust is not just a relational thing. Trust is something that is definitely decreased by our government system. So when our healthcare system takes a neutral stance in terms of building trust with immigrant communities, it essentially simply reinforces the broken trust that was there in the first place. And what I think can't be made explicit enough in terms of looking at the fact that this isn't just a toll that is taken on the women and people with cervixes in the community that are impacted, but social workers and community health workers from one county to the next may have a completely different set of resources. So which county you live in and the policies that county sets could be the deciding factor in whether you are screened, whether you are treated. And I want to just emphasize that creates some significant disparities, but these are local policies that local public officials make and that have an impact, not just on people in the community, but on all of us that work in the community as well.
Marcela and Autumn.
I don't know how to take the hand off. Oh, there we go. Sorry, I just have to add this last piece from the research study that I said was funded by your local American Cancer Society branches. They were participants in this. So this was a really local sort of project. It came up many times, the idea that women who are Hispanic, who are dying or have died of cervical cancer, that those stories are silenced or silent. And so Alma, thank you very much for being here. And thank you for sharing, you know, your mission of sort of being the voice and being open about that and encouraging others, you know, to be willing to share that. And I think that I just want to make sure that people hear that we talked and we met with folks who felt like these stories and these women are dying and nobody knows about it.
I think at the end of the day, the biggest thing as for being a woman, whether you're Hispanic or whatever, you know, nationality you are, is just to know that we matter. We matter to somebody. And, you know, it's so sad to listen to the stories of people that do not have health insurance coverage, because what options do they have? You know, to me, I hear those stories and their option is death. and it should not be like that, because we all ultimately matter. And I think that in order for us to make change, our voice has to be heard. We have to be open about it, and just get out of ourselves and our, we have to be vulnerable ultimately to be able to share these stories and to say, hey, I survived that, you can too. But at the same time, when there is such a discrepancy in the way a person is looked at because either they have insurance or they don't, we have to be the voices to change that.
Thank you, Alma. I like this theme of trust, and that Dr. Nava, you brought in that trust is not just a relational thing, it's a policy thing as well. And so I like to start to direct us toward kind of where we go from here, especially when it comes to building trust. And so, James, I'm going to ask you this question. You lead a team of community health workers, and I know that part of the role of the community health worker is to build trust. So can you tell us about the value of community health workers when it comes to addressing some of these disparities?
Yeah. As most of us may know, community health workers are advocates and representatives and have actually lived in the community that they serve. And so they have an intimate knowledge of the resources in the community, as well as the movers and shakers and stakeholders. And so in bridging that gap and establishing the trust, we really see community health workers as a solution to achieving health equity. And along those lines, and I may be jumping the gun a little bit here, we at Cancer Care Services have got involved in a training that is focused on community health workers delivering education on breast and cervical cancer, and then delivering that education to underserved communities and triaging those that they are educating to screening resources. And so community health workers are a crucial part of this equation in making sure that those that need the services are getting the services.
Thank you. And I know that part of the community health worker, the community health worker's role is to be sensitive to the specific needs and identities of the communities in which they work. And so, Crystal, I'm swinging this question to you. Before the panel, you talked about cultural sensitivity, especially when it comes to educating and then providing prevention and treatment for cancer. So can you talk about what it means and what it looks like?
Yeah, I think, so right now I do outreach out in rural communities, and I just, the delivery of the message is going to be different in rural communities than it is going to be here in Tarrant County. And so I don't know if you guys have heard, but Moncrief Cancer Institute received a $9 million grant to provide cancer screenings here in Tarrant County. So here in our own backyard, and which is really exciting. But along with that comes, our marketing strategy and delivery. We have to pretty much, start from scratch, because we have never really targeted the communities here in Tarrant County. And of course, as you guys know, each section of Fort Worth looks different. West Fort Worth looks different than South Side. I know Carlene has helped me book a few screenings here in Lake Como. And so we have to make sure that we are culturally sensitive and culturally relatable to those communities as well. So, if I'm going to Lake Como and I know that it's a predominantly Black area, I'm going to put a picture of a Black woman or a Black man on my marketing materials. And also, whenever I speak to them, make sure that I have relationships with those churches. I have a really great relationship with Pastor Tatum at New Mount Rose Baptist Church. So even though I'm not Black, he's a Black man, and he's a community leader in the 76104. And he's a great advocate, and I go to him for anything and everything that has to do with that community. And he has been doing a wonderful job. But if I go to North Side, that is a predominantly Hispanic area, and a lot of people there, they speak Spanish and they feel comfortable speaking Spanish. So that's what I'll do. I'll do whatever it is that makes that patient feel comfortable making sure that we are here to serve them and making sure that we are here to provide those services. And then going back to the immigration thing, you know, if I go to Northside and I know that it's a predominantly Hispanic area, I know the first question people are going to ask me is, you know, well, what about immigration status? So I just get it out of the way and let them know, hey, regardless of immigration status, you are still eligible for this free screening. And it's just a way of building that rapport and building that trust and getting those, you know, I don't want them asking me. I'd rather get it out of the way and let them know that we're here to serve them.
Thank you. And because we've been talking about the kind of relational aspect of trust, trust building, Alma, if you could close out this portion, if you have some suggestions that maybe providers or researchers could do when it comes to building trust, so that people who may feel like cervical cancer is stigmatized feel okay interacting with the healthcare system. And maybe if you could do that in less time than I asked this question, that would be great.
Okay, I will say this. When I was initially diagnosed, my physician was a man. And he told me that I had HPV, and that's all he told me. And the only thing that I knew about HPV was that my friend's daughter had HPV and she was fine. He told me, you know, come back in 6 months, and that was pretty much it. So I didn't know anything about HPV. One of the things that I have learned through this is words matter from the physician. You know, I went through, I ended up not going to the doctor in 6 months because he just said, come back in 6 months. Had he told me, if you don't come back in 6 months, you could potentially end up in the chemo chair, I guarantee you I would have been back in 6 months. So it was about a year and a few months before I went back to the doctor and then was diagnosed with stage 3B cervical cancer. I went through an entire round of chemo and radiation, and it literally took me to the brink of death. And I had decided that I am not, there was no way I would do a second round. And when I went back to my oncologist, that's exactly what she recommended. And I had already prepared my family. I'm not going to do it. I can't do it. And she sat down and she really had a heart-to-heart talk to me and told me, she's like, Alma, she said, if you were my sister, I would be telling you the same thing. She said, I just feel like if we do the second round, it's like putting the icing on the cake. And so I share that with you because it's important, and the words matter. In order for me to have gone through that second round, I had to trust my physician. And I think that just building a rapport I think that when someone is diagnosed with cancer, every single word that our physician gives to us, we're holding on to those words for some type of hope. So I just think that when it comes to trusting a physician, I think especially with the diagnosis like HPV, that it's important to let your patient know the importance of coming back, the importance of following through, the importance of, hey, if you don't, come back, it may potentially turn into cancer. I guarantee you, had I known that, I would have been back in my physician's office within 6 months, but I didn't. And, and a lot of that is responsibility on our own, to when we're diagnosed with something, to do our research. But, again, we get busy with work and taking care of our family and making ourselves last. So, I just ask that every physician that's on here, that as you train other physicians, to make them understand that your words matter. And that's where we're gathering our trust from, is the things that you're telling us.
I think I'll give you the last word. We have more to discuss, especially when it comes to building trust through the policy element. So we'll hopefully come back to that after we have our breakout rooms. But for now, we have a 5-minute break. And then at 11:55, we'll come back. You'll be sent into breakout rooms with a member of the panel. You'll have about 10 minutes to discuss a few questions with the panelist, and then we'll come back and ask some questions from the audience. So I am going to play a window from South Africa in case anyone wants to see what that looks like. And I'll see you in about 5 minutes. Everyone here. So we're opening up the floor to the designated person from each breakout room to ask a question of our panelists. So let's start with breakout room 1. If you know who you are, the designated person from breakout room 1, if you can go ahead and unmute yourself and ask either one person or the whole panel your question.
This is Rosemary. I think I was in group 1. Okay, thank you. We had a couple of questions, but both of them I think are probably for Marcela and Nava on the panel. And one is the question I had was related to insurance. And, you know, the discussion focused mostly on immigrant women who may not be eligible for insurance in the state of Texas. But we know that there's a lot of other Latinas that are eligible for insurance but haven't enrolled. And so do we have an idea of what the scope of that group is? Because I think we could, you know, cut this pie into slices and focus strategies on different populations. And so the second question was, what are the differences between counties? Is there a resource that we can have? Because our mobile health program, I'm the director of the mobile health program at Texas Health Resources, and we travel throughout 16 counties providing well woman services and cervical cancer screening. So that would be helpful as a resource.
Go for it, Marcela.
Sorry, it took me a second to unmute myself. So the first question, which was, I'm sorry, there were 2 questions. One was just about the county differences, and the first was, remind me again.
About insurance that for women that are eligible for
Yes.
insurance but have not enrolled. And there could be a variety of reasons for that. They just maybe not know that they're eligible.
Yeah, no. So I'll say that, you know, when we look at health insurance statistics, especially in the state of Texas, which leads the country in the rate of uninsured, and this part of Texas also leads the country in that rate, the grand majority of folks who are eligible for health insurance but are not enrolled are Hispanic children specifically. And one of the things that we haven't done well in terms of policies and organizational strategies is coordinate and identify those targets for inclusion. So being able to, you know, coordinate in terms of communication messaging that targeted, say, US born insurance eligible children in these families, young adults in these families, would certainly be a viable strategy that simply hasn't been implemented, because again, we see how fragmented we are. There may be one organization that's doing screening, another organization is doing adolescent outreach, a completely different organization is doing you know, survivorship services. So there are opportunities to do some really strategic messaging that aren't happening. And then to your other point, is just about county by county differences. Part of what makes this such a challenge is that the continuum, as Dr. Kiber has done a great job, I think, of emphasizing in previous conversations, the continuum of cancer, the many different points at which women may, or which people with cervixes may receive assistance, can be drastically different from one county to the next. And so if we look at just Tarrant County and Dallas counties, for example, it's possible that you could invest a lot of money into translating documents, training community health workers, promoting screenings. But within Tarrant County, even if you had the best as massive screening outreach efforts possible, you would still run into county policies that are are set by public officials that are elected in the county, where essentially at that point, there would be no source of funding, no source of public funding for treatment. And it's important to also just remember that health insurance or healthcare costs, research has found, are actually more expensive for folks without health insurance than folks with health insurance, if we just look how much is charged in many cases. So in Tarrant County, you could very well hit a wall in terms of eligibility for services that a few miles down to the east into Dallas County, you would not hit just because of those county policies for who gets financial assistance.
Thank you. And thank you, Rosemary, for that question. Let's swing to room 2. So this was the room with Marcela. And for the interest of time, I would say if you have more than one question, just choose one to share. So breakout room 2.
I didn't do a good job of helping with that. I think Precious was in that group and really had a great point. Just, I don't know if you want to wrap that up as we talked about.
Well, we talked about, briefly touched on the fact of the difference between having insurance and not having insurance. And on a personal note, my insurance got cut in the middle of my treatment. And I just gonna explain the difference was like night and day. And also talked about what we could do, especially for me who's in the Arlington area, service to Arlington area as a community health worker. I'm working with a lot of Hispanics and a lot of Africans, not just Hispanics, but a lot of Africans as well. So besides the trust issue, they want more information, and it seems like I don't have enough information on the subject matter. So you can send them to the internet, but they're the kind of people that like to feel and hold like tangible stuff like paper. Give them a flyer. Have some Spanish some documents translated into Spanish for the Spanish community. The African community loves paper, so they like flyers. And those are things we talked about, and I think we talked mainly. We spend a lot of time on the politics of what can we do, because everything's so politicized now. How can we, as community health workers or as agencies, how can we help? How can we resolve matters that are so politicized? And I think Marcela came up with, we just have to, the possible way to do it is if we sit face to face with our leaders and discussing these issues with them so they can see it from our viewpoint. And those were the topics that we, those are the things that we discussed.
Thank you. That's a great summary, Precious. Let's go to room 3. You had 2 panelists, Crystal and Autumn. So room 3 designee.
We also were lacking in choosing a designee, but Jasmine or Denise or Trelissa, if you have any questions that you want to follow up with the group here.
Hi, this is Denise. So not necessarily a question, but also wanted to just thank Alma for sharing her story, and we really appreciate it. And I think we were really impacted by some of the statements you made, and I think that really highlights the importance of having a community health worker present in just the interactions with any healthcare providers. We talked about even from the screening to really speaking with the oncologist and just the whole continuum of care, right? And so again, just thank you to Alma for sharing that.
Thank you, Denise, and thank you, Alma. Let's move to room 4. This was Carlene's room. So if you are a designee for room 4, this is your chance to ask your question.
Okay, so I was putting Melanie on the spot, but she threw it back at me. So it seems like our theme is pretty much the same. It's centered around the community and state policies. And what can we do in Tarrant County so that we can look more like Dallas County, which is less than 30 minutes away? So are there any grassroots efforts going on in Tarrant County to try to get some of those policies changed? And I guess that would be a Marcela question.
Yeah, great question. So this is the grassroots effort right here. This is it. This is such a politicized topic, and I can't underemphasize that. Nobody here wants to risk their job. Nobody here wants to risk a promotion or political censorship. We understand that. But together, as a coalition or as a collaboration of public health and community health and research and academics, we can speak in a more united voice that says these are the types of resources and the types of policies we want to see in place. And collectively, we do have a voice. I will say that there have been grassroots efforts in the past, and they have not been successful, in large part because they did not include healthcare providers and professionals and community health workers. And while we have voices that are being silenced, I think it's important to remember that by not working toward having a voice together, we're also part of the problem. Even though we individually may not have power to change these policies, collectively, we can choose to do that. Or collectively, we can choose to acknowledge that we're simply not doing anything.
Thank you. Room 5. I'm not sure you had a panelist actually, but I hope that meant that you came up with a question on your own. So if you're in room 5, what's your question?
Yeah, I think I was the panelist in room 5. And
okay.
Yeah, Lydia, she had a question for the panel.
Our question was, are there resources available to other undocumented population or uninsured population? Like, for example, in other counties besides Tarrant County, such as Denton, Carlene, Parker, or Grayson County?
I think I don't want to dominate here. I think the community health workers are likely to know a lot about that, but I'll say in terms of, there is no current source of public or private funding that is dedicated to funding cervical cancer treatment for women in Tarrant County. So while there may be occasional pockets like Cancer Care Services, like Moncrief, that get grants or private funding, I think it's just really important to emphasize that the ability of one organization to get enough funding to be able to cover the need is simply not doable. So this cannot fall on one organization or one healthcare system. The problem is simply too large and it's not sustainable. So the funding that there is stretched very, very thinly to cover many, many groups and many other types of cancers and many other spaces. But it is important to, again, remember that the disparities here are significant and still, worth understanding how to collaborate. It's a need, I guess that's the way to say that. It's a need to think about how do we fund services in this area? And that's a conversation we need to have together.
And I just wanted to touch a little bit on the collaboration of it all. Crystal actually alluded to it earlier, but we've over the past couple of months have really been able to establish a strong relationship where we are partnering, with Moncrief in certain underserved communities to do screenings, although they are breast cancer screenings. By establishing that relationship and that collaborative, we are able to firmly position ourselves at different points of the continuum to make sure that those that need us are finding us.
Crystal or Carlene, do you have anything quick you'd like to add about that question?
I just want to add one quick thing. Our mobile, we do provide mammograms and also pap smears. The only thing, I know I told Carlene this right now, because the COVID restrictions are going down, we will be able to offer pap smears as well on the mobile. So hopefully James and Carlene, the upcoming mobiles will be able to add in those PAPS services soon.
Fantastic news. I love it.
Yes.
And I think that although we are doing breast cancer, we are giving them information on the cervical cancer screenings, because we have to realize that they can kind of go hand in hand. It's all a women's issue. And I believe that Texas Health, and Rosemary can correct me if I'm wrong, Texas Health unit is back in service now and out in the community. Because the issue is that we need everybody. We need boots on the ground. We need everybody that's available to get these screenings done to come out there and help us.
Absolutely. This is
Carlene.
Rosemary, and we have 3 mobile health teams that are ramping back up now that the pandemic has kind of waned a little bit. And so each one of them will be and is staffed by a family nurse practitioner. And so they're fully equipped to do a comprehensive physical exam on every patient that we see and be able to follow the patient up, whatever the results are.
Thank you, Rosemary. Let's go to room 6. This was my room. So Laura, you had a question if you could ask of the panelists.
Yeah, absolutely. Thank you all for taking the time to speak with us today. It was a very eye-opening talk. And then for those who are starting their community health worker journey, what advice do you have on the individual level for building that trust and finding and providing those needed resources for our communities?
Carlene, if we could start with you and then we'll go to Crystal.
I think one is, just get out there. If you're a friendly person, you don't mind talking to people, you first have to listen. So just be willing to listen and let them kind of, I say unload, because some people just don't know what direction to go or where to go or anything. So, I would just let them talk. And in their talking, and if you're listening to them, by the time they're finished, and it may not be the first interaction, a lot of the people that we come across, it's not the first time they trust us and we can just give them whatever they need. It's about making yourself visible in the community. So you have to be out there. You have to put yourself out there, and you have to be transparent, which is what I liked about Alma. We've got to be willing to share our stories and let them know that, it's not a death sentence if you open your mouth and ask for help.
Thank you, Crystal.
Yeah, I'm just going to echo Carlene, really putting yourself out there and making yourself available, and, just providing a listening ear and trying to provide those resources where you can. And also a quick plug for the community health worker, the DFW CHW Association. We are based out of Dallas and Fort Worth, and we have all sorts of resources, and we connect CHWs to other CHWs. And so if you would like to learn more about what community health workers do and how to get certified, I can put the website in the chat, but it is dfwchwassociation.org. And I will go ahead and put it in the chat for those of you who want to check it out.
Thanks, Crystal. And we will briefly take our last question. This was room 7 from Erika in Alma's room, who is the designated question asker.
That's going to be me. I don't remember who it was, but someone mentioned, we were talking about the HPV vaccination, and that it also will prevent 5 other cancers. And our question was, what are those cancers? Are they different strains of HPV?
Dr. Thompson, can you respond to that?
And even though I was in the same room, so the five other types of cancer caused by HPV include vaginal, vulvar, penile, anal, and oral pharyngeal cancers. And in fact, we're seeing an increase in oral pharyngeal cancers, particularly among men. It's exceeded what we've seen for cervical cancer now. So those are the other 5.
Thank you. So to close out our panel, I'm going to ask each panelist to share maybe one sentence. What's one takeaway that you hope audience members glean from your portion of the panel? So Carlene, because you're the top left, I'm starting with you. One sentence, takeaway.
Be open and transparent.
Beautiful. James.
I'm sorry. Patience. This is a process that is going to span across, many years, many generations. And so, we definitely need to stay committed to this work and be patient with the process.
Thank you. Autumn.
I'd like to say that we can hope and work towards no more cervical cancer deaths.
Thank you. Crystal.
I would say early detection is key.
Beautiful, concise. Marcela.
Shared accountability. This is something that we can all do something about, and rather than just talking about the issue, we can all agree to continue talking towards solutions and agreeing that we all share in the accountability, or we all share in the deaths that we're talking about of these women.
Thank you. Erika.
I think to build off what Marcela shared, collective impact. We all bring a different lens to this, and we can all work together to achieve that common goal.
Great. And Alma.
Gwendolyn Grace in the group said that we should never be placed in a position to ask the question, can I afford to live?
Thank you. Thank you all for coming out to this panel. We're 1 minute over. We're going to put up an event survey slide right now. And if you have 2 minutes to answer 3 quick questions about your experience with this panel, then please go ahead and do so. But I'd like to give our panelists just a digital round of applause. Thank you for your time and for this collaboration. This is an example of public-private partnership. So thank you for your coming out and sharing. And we hope that you have a wonderful rest of your Thursday.